Welcome everyone to our webinar on the empathy effect. My name is Kathleen Bonvicini, and I am the CEO of the Institute for Healthcare Communication. I see names of some folks that I know very well. I see some new names for me, so whoever you are, welcome, and we'll be able to get a sense of who you are and what you do in a few minutes. I'm joined by a terrific IHC team. And before I introduce them, I'd like to tell you a little bit about what we want to do today. We have an agenda that we'd like to cover, and the first thing we'd like to cover is to talk a little bit about why we developed this curriculum, the empathy effect, and kind of go behind the curtain a little bit and let you know what the empathy effect curriculum is all about, how it's different than many of our other workshops at IHC, and how there's similarities. And we have a great team to do that. So we're going to hopefully accomplish that today and talk about how we use the premises as the evidence base for this workshop, and at the same time utilize our usual IHC MO for teaching, and that is through experiential learning and practice. So we have our co-leaders today on the call, on our webinar with us as well. I'd like to introduce you to 4 people on the call who you'll hear from in a few minutes. Dr. Michelle Manchoff. Hi, Michelle.
Hello.
Michelle is one of our senior trainers at IHC and actually has been with IHC, I would say, about 20 years, thereabouts.
That would be correct, yes.
Very experienced clinician and trainer for IHC. And Michelle happens to be one of the 2 co-leaders for our newest curriculum, EE. We're calling it EE, which is the empathy effect. Our second co-leader is Elizabeth Morrison, and she, by way of training, is a licensed social worker out in California and has her own consulting business and has worked with IHC for probably close to 10 years now. She's a senior trainer and, like I said, a co-leader of the EE. We also have 2 other members of our team, and that is Barbara Andrews, who is IHC's Director of Training and Projects. Hi, Barb. And we have Catherine Stewart, who many of you know. She's in our Canadian network for IHC, and she is our Director of Outreach and Quality Outcomes. So welcome to our team. I'm happy to be here, and I'm happy that all of you have joined us. And just to let you know, we are recording this webinar. So for colleagues that couldn't make it, or if you yourself want to revisit this webinar, please do so. Let's see. What I'd like to start with is just talk a little bit about IHC very briefly, because some of you are new to us, and we are a nonprofit, nationally accredited organization. What I mean by nationally accredited is we are accredited to provide CME, which is continuing medical education or continuing education professional development, and for nursing and for physicians. And also our courses have received the blessing of many accrediting organizations. So many folks who take it, social workers and other clinicians, can also get accreditation as well. We have been around nearly 30 years, actually over 30 years now, and we have developed over 15 communication workshops. So that is our niche. That is our focus. We are very interested in how people interact, and our first focus, of course, is how healthcare professionals interact with patients and family members, and we're also interested in focusing on the communication that happens between the healthcare team. So regardless of who you are in the healthcare involvement, we are interested in helping you improve your communication skills. Let's see, the other thing that we do at IHC is we collaborate. We work with several partners. We've partnered with over 200 healthcare organizations throughout mostly North America, so in the United States and in Canada. And we have provided not only workshops, training, where we go out and speak with healthcare organizations and clinics, but we train others to do that same thing. So we expand our reach by providing train-the-trainer programs. And at this point, we've trained over 2,700 professionals like yourselves who teach one or several of IHC's workshops. So at this point, we've conducted over 13,000 workshops thanks to folks that are trained to teach IHC workshops. So that's a little bit about IHC. I want to remind you, as in many webinars, you have the opportunity to chat, so to ask questions, provide comments as we go along. And just to let you know what we'll do, just a little housekeeping, is that Catherine and Barbara will be noting the questions or the comments that are out there, and we will reserve time at the end to address those questions. And if there's not enough time, we plan to gather all the questions with answers and sending it out as an FAQ document to everyone on this call. Okay, so let's move along and talk about this program. The Empathy Effect program was developed thanks to the funding from Blue Shield of California Foundation. And like the Blue Shield of California Foundation, IHC has always been interested in teaching core communication skills specific to one particular powerful skill, and that is empathy. And we know from the research that empathic communication is probably the most powerful skill that you can use in the healthcare environment. And if I can say, in just interacting in relationships that matter. And what we've also found that empathy doesn't always come so naturally, particularly when we're working with patient populations or certain situations that for whatever reason we have biases and judgments that sometimes get in the way. That's what this program is all about, recognizing the fact that all of us have natural biases, implicit biases, judgments that sometimes can create disconnection between ourselves and our patients. So this course acknowledges those biases, they normalize those biases, and they talk about how those judgments and biases can actually leak through in our nonverbal or our verbal conversations with patients and family members. So we're happy that we have this funding to do that. We had a terrific Empathy Effect development team that are listed on this slide. Michelle and Elizabeth led that charge. Also on that team, as is Barbara Andrews and Catherine Stewart. We also had a wonderful user insight group that, again, are listed on this slide. Some of you may be on this call, so thanks to all of you that are on the call that served on this insight group. And those are folks that are in the trenches, that are actually working in a lot of safety net clinics and community healthcare clinics and doing the hard work, that really understand what some of the challenges are in demonstrating compassionate care and empathy in those conversations. We also had another group of, I guess if you will, subject experts in the field. And these are folks, again, listed on this slide, that have worked in the field and have contributed to the research in the field that has informed our curriculum. The next thing I'd like to do is just find out who is on this call, geographically, where you come from. So if you can, let's see, I think just do a poll. I think Catherine is tagging this. We're doing this by chat, are we?
No, I'm going to launch a poll for you.
Okay, beautiful.
And so, you can all respond.
Oh,
there we go.
Okay, so
just give it a couple of minutes.
4 choices.
Wow, outside of North America. I'm impressed.
Enter your data. Yeah. I think we have close to 60 people on the call, or
64, it says right now.
people that are on the call.
Yeah.
And I know we heard from lots of folks that said they certainly can't make it, but do want to get the recording. So that's terrific.
So I'm going to end the poll now. It looks like it's settled down. So I'm going to end it, and I'm going to share the results with everybody.
Oh.
Okay. So we have 2% outside of North America. I'm very interested in where that might be. 29% in Canada, 22% in the United States, and specifically 47% of those in the U.S. are in California. So that's terrific. Welcome to all of you. Okay, we're also interested in what you do in your professional life. So if you don't mind using the chat button in the webinar to let us know what is your primary professional role. If you have more than one you want to share, please do so. So we're going to have those listed in there. And we'll get a sense of who they are. Clinical safety lead. Let's see, veterinary consultant, Michelle, hello. Michelle Harcher. Mental health therapist. Site manager, registered dietitian, registered nurse educator, program manager. This is great. Sorry, for those of you who can see me, I have a little visitor at my home, and my newest addition to my family, Tina, just entered the screen. I apologize for that. Pediatric social worker. Nice. Hi, Katie. Excellent. Self-management coordinator. Yeah. The beautiful thing about this new curriculum is that it's intended for anyone who works in the healthcare arena and has some contact with patients and families. That's the beautiful thing about it. So it sounds like we have a pretty diverse group with us, and I do hope, as you hear from our co-leaders today about the nuts and bolts of this curriculum, that you ask a question that pertains to you in the environment that you work in. The other thing I want to say is that we had our first inaugural training held in California that was attended by 7 organizations that are listed on this slide. It was held in Sacramento, and we had a beautiful time there. I was part of that training team along with Elizabeth and Michelle. Catherine was there as well. And there we are. It's a smiling bunch. I forget how many there are of us. Was there 20? How many people were there, Catherine?
14. 14 learners. 14
learners, and then 3 faculty who provided the training. And we had a wonderful time, and thank you to all of you that were involved in that program. It's hard not to smile when you're in California. So there we are. The next thing I'd like to do is just go over some housekeeping items so we can get right to talking about the curriculum and respond to some of your questions. As I said before, we will take any questions or comments that you have. Please use your chat button to do that. We will be recording this, so it's available for review or to pass along to some of your colleagues who couldn't make it. The other thing is that if we do not get time to answer your question, we will send out a document later with the questions and responses. What I'd like to do now is start by showing you a very short video, 3 minutes long, that was recently made and while we were out in Sacramento, actually showcasing the empathy effect. We're going to have you watch that, so hopefully your audio and visual is working, so let's take that away. We'll have a link to that on our website that we can provide. So why don't we move on? It's too bad. I mean, you'll get a chance to see it. What I'd like to do is turn this over to Elizabeth and Michelle, our EE course leaders, who will talk about this workshop in more detail. So I'm not sure. I think Elizabeth may be going first.
It's all Elizabeth.
That's a great introduction. It's all Elizabeth.
It's all about Elizabeth.
Hi, this is Elizabeth. Michelle is my partner in developing this course and the other senior trainer for this course. She has to leave a little bit early today, so I'm going to be talking. Many of you on the phone, as I was looking at people's names, know Michelle. And so I'm glad you've had that contact with her. I was looking through the names, super happy to recognize people who were our trainers that are now trainers in the Empathy Effect, that were at the inaugural Train the Trainers in Sacramento. It was really nice to see your names on there. I also, some of the people on the user insight group that we shared with you that had input into this curriculum are on the phone, and the expert advisory committee. So it's really nice to see people's names because it was such a team effort to create this. And so I really appreciate all of you who are here today for the input that you had on this. And I'm just going to talk just a little bit about some of the bones of the course. And of course, some of you on the phone, are really familiar with this and might have even conducted the course yourself now at this point. I'm going to talk a little bit about the bones of it and the research. For those of you who know the IHC, it's a very, very research-based organization, and all of the workshops have a very heavy research foundation. So I want to talk about a little bit of that because I think it's particularly interesting research when we talk about the impact of empathy on healthcare outcomes. So let's go to the next slide, Catherine. So the workshop goal is really to help, and we say enhance because those of us who work in healthcare, everybody, all of us as humans, of course, have empathy. And for those of us who work in healthcare, most of us chose this because we care about people and we want to sort of put that into action in our professional lives. And so we aren't teaching empathy, we aren't teaching that or giving that to people. We're just wanting to enhance our skills in actually conveying it. And one of the things that we talk about a lot in the workshop is that even despite often our best attempts, when we feel very caring about someone, sometimes we don't always convey that in a way that feels effective. And I always like to say, if there are any parents on the phone, that if you've ever had one of your kids say, "You're not listening to me," even though we felt like we were, it's a really good example of how people we love very much and care very much, sometimes it might not have hit home how much we care. So we really focus in this course on the skills that convey that care. So there's 3 premises in this workshop, and for those of you who are familiar with the IHC's workshop, there are premises that are the foundations for all the other courses as well. And the first one for the empathy effect is that empathy is healing and judgment is harmful. And so really the way we talk about this is like a seesaw. That typically the more we're able to convey empathy, the less we're conveying judgment. And the more we're conveying judgment, the more we tend to, the lower our empathy conveyance is. So when we talk about empathy, we're using a very broad definition. And you can sort of see on this slide that there's sort of all of these words in a bucket that we are putting under empathy. And the reason for that is there's quite a bit of sort of linguistics and academic exploration about exactly what is empathy and, the difference between that and sympathy and compassion, etc. And for the purposes of this workshop, we really are talking about it in the broadest sense, as compassion, as having a big overlap with what most of us in the healthcare field know as trauma-informed care. In the behavioral health field, I'm a therapist. We sometimes talk about it being the therapeutic alliance. Often it's referred to as respect. Sometimes in the literature, it's referred to as courteousness or civility. Sometimes we'll see that in the literature. So a very broad definition of what empathy is. And the reason that this is a pretty bold statement to make in healthcare, it's pretty bold to say that empathy is healing. And so we better have some research to back that up. And in fact, we do. One of the things that we know from, about 60 years of research in the behavioral health field and about 20 years of research in the medical field is that the empathy that is conveyed successfully has a significant impact on healthcare outcomes, a significant impact. It also has a big impact on patient or client experience, which is also related to healthcare outcomes. And also, in a kind of a win-win universe, the better communicators we are in terms of conveying empathy, the better our job experience is as healthcare professionals. And we have a lot of research around that too. So the next slide, I want to talk just a little bit about the research on health outcomes, if we can. So this is just, I just want to say, this is really just some selected conditions that when empathy is effectively conveyed, show significant improvements. So the research is so broad and so deep, and at this point, a couple decades long. It's really interesting, and we have a 60-page annotated bibliography, like we do for all of the IHC workshops. And so if anybody would like to see that, that is on the IHC website, which we'll point you to at the end. It's really fascinating to look at. I've developed this sort of obsessive interest in this, and Michelle too. And so frequently we're trading emails, about new research that we see in this area or research that we see in other fields that is directly related to empathy's impact on treatment outcomes. One of the most interesting pieces of research that I've read in the last 5 years is about the impact on the common cold. So when people come in for care for the common cold, when empathy is effectively conveyed by the healthcare team, we see the severity and duration of the symptoms of the common cold lessen. And part of the reason that that's so fascinating, as most people know, there isn't any other treatment for the common cold. So this is really a case where we see empathy is actually the primary treatment for the common cold. Empathy has an impact on pain control. For all of us in the healthcare field, we know that chronic pain is incredibly common. It's almost twice as common as diabetes, and can be very difficult for health systems to try to manage and be helpful with. And we know that when empathy is effectively conveyed by the healthcare team, that self-reported pain levels go down. And of course, I would say, if you've ever tried to interact with a small child who's been hurt, you know this, that when we validate and convey empathy, that they will report feeling better quicker than if you grew up like me and your mom said, "What are you crying about? You shouldn't have been running," but it hurts a little more. My mom's not here, so I'm sort of throwing her under the bus, but we know that empathy has a big impact on substance use disorders. And I'm going to talk a little bit about the opposite of that, judgment, what that does to substance use disorders. We see clinical improvements in alcohol and other drug use disorders when empathy is effectively conveyed. And we see big differences in anxiety, diabetes, and depression. And these are all clinical outcomes that are improved just by successfully conveying empathy. And like I said, that's not all. So I really encourage people to look at the bibliography because it's so interesting. Let's go to the next slide. So we know that patient experience is so closely related to patient clinical outcomes that one can be used as a proxy measure for the other. They're very, very closely related. And we know that patients typically say that the most important factor in their care is how cared about they feel. In literature, it's worded some different ways. Sometimes we see that worded as respect. Sometimes we see that worded as courteousness. It kind of goes into this bucket of feeling cared about. So we see increased satisfaction, When people feel more cared about, they actually disclose more important health information. People don't tend to disclose when they feel judged. And then that makes it much harder to make an accurate diagnosis. We see improved adherence, meaning when we feel cared about by people, we're more apt to trust their recommendations. I just had an example of this not too long ago, that my daughter had seen a specialist and my husband wasn't there. And when we were leaving, he texted me and said, "How did that go?" And I texted him back and said, "He didn't listen well. We're going to have to get a second opinion." And I realized as I was texting that what had happened was, because I felt like this person was dismissive and not caring in dealing with my daughter and I didn't really trust the recommendations. I didn't really feel like he had heard us well, and I was wanting to go see somebody else. And that's an example, I think, of how ingrained it is in us as humans to not follow someone's recommendation when we don't feel like they care about us. And then we see an increased understanding of health conditions. So when we think about health literacy, when we think about self-management, when we think about self-efficacy with chronic conditions, we see that when patients and clients feel that they have sufficient empathy from us, that there's an increased understanding of their condition. Let's go to the next slide and talk about our experience. Of course, for those of us on the call, we're healthcare professionals and we're also patients. So I'm sure for us, we relate to both of these pieces. For us as healthcare professionals and for our colleagues that we work with, the better our communication skills are and the more able we are to successfully convey empathy, even under difficult circumstances or even under conditions in which we've identified we may have a bias or a judgment, we know that our job satisfaction goes up, that our job experience goes up. And some of that is because we have an increased number or percentage of rewarding interactions. So for all of you who see patients, you know that one or two very unrewarding interactions can really sink your day. They really weigh on us. It starts to feel, why are we doing this? Or we feel drained. And so the better we are at conveying our care, the more rewarding our interactions are. And that percentage just keeps going up. We have decreased sick days. So as employees, when we're better able to communicate empathy, we actually have less call-outs for sick days. We see that there is a positive correlation with decreased burnout, the better our communication skills are. I want to say something about that that's interesting. When we talk about empathy, we do separate cognitive empathy, which is perspective taking, meaning in our minds, we think about what other people are experiencing and we can imagine what they're experiencing, and affective empathy. And affective empathy is feeling what other people feel. So when my daughter cries, like she did the other night, because we had picked up a stray dog, taken care of it, and passed it on to a foster home that was going to then adopt this dog out. And when she was on the way home, she cried the whole way home and felt like she was letting the dog down. She felt like the dog had looked at her when she'd handed this dog off. And I felt what she was feeling. When she was crying, I felt like crying. I felt torn up inside just like she did. And sometimes as health professionals, we have that feeling. We'll feel what our patients are feeling. And that is actually associated with burnout. So if we're feeling what people are feeling day in and day out for a big percentage of the day, it's very draining. And that isn't what we're talking about when we're talking about increasing empathy, because many times people will say, I don't need more empathy. I have too much, it's so draining to me. And so, what we would say to that is, yes, we get it. That isn't what we're talking about. It's really an increase in cognitive empathy and the ability to convey that to people through communication that we see a relationship to decreased burnout. And then we see a decreased complaints. We know how hard this is on employees when you get a complaint. You might treat hundreds of patients and this one patient, files a grievance or complains, and here comes grievance and wants to investigate, or a written complaint, or you have to hear from a supervisor what a patient said. And it can feel terrible when we're working really hard to help people to have that happen. And the better we are at communicating our care to others, we have a lot less complaints. There's one area that I want to say something about with that, and that is with our receptionists in our front office. Our receptionists, often we don't think of them as one of the more important people on the healthcare team in terms of conveying empathy. Quite frankly, they are very likely, I don't want to say they're more important, but they're one of the most important places where empathy gets conveyed. And when it doesn't, it's one of the places where patients and clients really feel poorly and often complain about the treatment that they receive at the front desk. And it's also one of the places where receptionists then, who may not be highly skilled in conveying care, they may have a lot of unrewarding interactions with patients. And so we may see very low job satisfaction, and then we have sort of a cycle of bad job satisfaction and perhaps not optimal communication. So one of the interesting things about empathy is that it's sort of an equal opportunity skill, which means that there's a lot of research about physicians and their conveying empathy to patients and the impact of that. We also, though, have a lot of research on nurses. We have a ton of research on behavioral health providers. We have research on medical assistants, and we have emerging research on receptionists and their conveying empathy. And what we see is that health members outside of what we typically consider the treatment providers, behavioral health providers or physicians or other medical professionals, that we see that there's an equal impact on patients. And so in that sense, it's just as important that our team members also are able to communicate this skillfully. So let's go to the next slide. This is our, oh, yeah, that's what I was just talking about. We can go on to the next one. I wanted to go on to premise 2. Oh, you know what? I'm sorry. Thank you for, well, you can leave it on premise 2. One of the things that I talked about in the very beginning when I said we think of empathy and judgment as sort of opposites, opposing forces on a seesaw, is that for every piece of research on the impact of empathy on healthcare outcomes, on the positive impact on treatment outcomes, there is very likely another study that shows the negative impact of judgment on treatment outcomes. And that research is kind of depressing, of course, and just as interesting. So we have research that shows when therapists convey empathy to those who struggle with addictive disorders, that it actually worsens the addictive disorder. And we have many other studies that show the equivalent in what we would consider medical conditions. For example, we have research that shows that when judgment is conveyed toward people who are overweight, that it actually worsens the obesity. We have research that shows that when judgment is conveyed, or when patients perceive judgment around their diabetes, that their hemoglobin A1C levels, their blood sugar levels actually go up, which is worse. So like I said, that research is more disturbing to look at and just as compelling. The second premise for the Empathy Effect workshop is that vulnerable populations experience greater harm by judgment and lack of empathy. And what we're really pointing to here is that empathy, the truth is empathy is good for all of us. It's like a vitamin, and all of us know what it feels like when we feel it, whether that's from our family members or whether that's from somebody at the dry cleaner, or whether it's from a healthcare professional where we're dealing with, very personal or important things. It's like a vitamin. It feels good, and it's good for us. And judgment feels bad, and judgment is not good for us. Judgment doesn't result in people making behavior changes. It tends to push people back from behavior changes. So even though we know that that's true of all of us as humans, we also know that vulnerable populations actually suffer more, that there's disproportionate harm for those that are most vulnerable when they experience judgment or lack of empathy. So let's go to the next slide and talk a little bit about who we think of when we think of vulnerable populations. And I'm guessing by looking at some of the names that I recognize who are here, many of us work in the safety net. I work in what we call the safety net. We work with people who are poor, who have been historically marginalized, who are what we might call out groups in terms of ethnicity. And so many of us might have this in common, that we're very familiar with what we consider vulnerable populations. These are just some examples. People who are poor, people who are homeless, those with mental health conditions, addictive disorders, immigrants and refugees, particularly in the political climate right now, those who have experienced trauma. Now, of course, we know this is not an exhaustive list, and in workshops, we really encourage people to say, we say, who else do we think of when we think of vulnerable populations? And really also to make the point that for all of us as healthcare professionals, many of us fit into one or more of these categories as well. So again, we may relate as patients and as healthcare professionals on this one. Let's go to the next slide. So we know that vulnerable populations, and again, this is very clear in the research, we know that vulnerable populations experience decreased self-esteem, that they have worse physical and mental health, that they have worse social, employment, and housing opportunities, that they have a much higher level of emotional stress and anxiety, and that there's a reluctance to seek medical and behavioral health services. And one of the reasons this piece is so interesting is because when people feel cared about, when they feel empathy, when they don't feel judged, as we talked about, they are more likely to self-disclose, and they are more likely to come in then to our organizations for services. So being able to successfully convey empathy as individuals, as a team, and as an organization becomes really a professional imperative in terms of serving vulnerable populations. Let's go to the next slide. So one of the things that we do in the workshop that I'll talk a little bit more about before I end is that we really prioritize and feel like it's very important to have a high level of interaction in the workshops to allow people to contribute and discuss and share their experience and practice. We developed what Michelle and I, for a long time in the development of this workshop, we're calling a popcorn quiz. And I don't know if that was because it was about, movies, or if it was just the idea that it was fast and people were sort of shouting out answers like popcorn. And so we picked a couple of our favorite questions in this for participants to do in a poll, like Catherine did for or like Kathleen did of asking where you lived. And so the first question is, which chronic diseases have the highest relapse rates? And we'll give you some choices. Go ahead and pick which one you think has the highest relapse rates and send it on in, and we'll tell you. We'll give you a minute. What do you see, Catherine?
It looks like it's pretty much ending, so I think everybody has contributed. Thank you. And I will share that with everybody.
Look at that. Yes. So as you can see, we have 52% who said addiction. A very, very common response. Absolutely. Diabetes was a second runner-up. So let's go to the next slide and we'll look at the answer.
Okay, just one sec. There we go.
Yeah. Very interesting. This is really why we put this into the quiz. As a chronic disease, addiction has a lower relapse rate than hypertension or asthma. And the way we would define relapse is stopping self-management behaviors and returning to symptoms. That's the way we would define it. So this is a little bit counterintuitive, or maybe different than what we've been taught, or different than what we grew up believing. Let's go to the next question. So what percentage of the population, including healthcare staff, so I would say including all of us on the webinar today, have experienced at least one adverse childhood experience? Many of you probably know the research on adverse childhood experiences. That really means a traumatic event or a difficult event, a substance, a parent that had an addictive disorder or was incarcerated, abuse or neglect. So what percentage of do people think of all of us, all of our patients, all of healthcare staff, just people in general, have experienced one adverse childhood experience?
Okay, I'm going to end the polling. There you go.
Okay. So we had 47% say 65%. So let's go to the next slide and we'll see what the answer is. Yes, 65%. So maybe 45 people on the call right now. And a huge percentage of our patients and our coworkers have experienced at least one adverse childhood experience. And for those of you familiar with the research, there's a dose effect. So the more difficulties we had as children, the more adverse childhood experiences in frequency and severity, typically the worse our health is as we age. So very interesting research and has a lot of implications for and was a driver for this curriculum, the empathy effect. Let's go to the next slide and we'll talk about the third premise. The last premise is that we all have judgment. And this is really just normalize the fact that this is a human, condition, that we all have judgments. And they're mostly unintentional. It's uncommon that we want to defend our judgments. Sometimes we do. Most of the time it's unintentional. And that it does show up. Kathleen used the word leak. Sometimes it leaks out. Sometimes it shows up. Sometimes it shows up in our language. Sometimes it shows up in our facial expressions. Sometimes it shows up in our organization in terms of policies and procedures and how we treat different people. I mean, an example of this that we've seen is in the substance, the addictive disorders field. Most of the large substance or addictive disorders organizations have come out with position papers around what they consider judgmental language. And that's things like a substance abuser or addicts. And that the reasons this is important is that we find that when we use those words, we actually treat people differently. We actually sentence them to harsher, and more punitive treatments or longer treatments, or sometimes don't let them go to treatment and want them to be punished in prisons. And that seems to be associated with our language. And so language is important. And we're all exposed to stereotypes and stigma. So let's go to the next slide. We talk about this in the workshop. We really invite people to reflect on where we get our biases. We sort of come by them honestly, I think, is what we're trying to sort of normalize for people. And just to look at all of the influences, within our family. And, I frequently share that I grew up, both my parents were immigrants, and my dad in particular. In our family, we were so conditioned to believe that hard work is basically, the harder you work, the better person you are. I mean, it is synonymous with being a good person. And that was so deep. It wasn't until I was in my early 30s and I had people bringing me disability forms in California where, health professional can write someone off on disability and they don't work then. It wasn't until then that I stumbled upon this bias that I had, and I realized that I had all these judgments about people. As soon as someone brought me a piece of paperwork around this, I wasn't interested in their story. I already had an idea. I was already sure what, that they should be working, and all the evidence of the bias and judgment with that. I didn't realize it until 15 years ago. And so, they go pretty deep often. So we encourage people to reflect on this in the workshop to really normalize this piece. let's go to the next slide. So really what we do, here, those are the three premises that, that the empathy effect is based on. And what we really do after we talk about those is we say, we're transitioning now to skills. Really, what do we do with these three premises? Well, what we know is that we can learn to continually enhance and improve our communication, to be increasingly effective at conveying empathy, in all kinds of different situations, with all kinds of different people, and we can learn to identify our biases quicker and more subtly, and we can use tools to be able to convey empathy effectively, to mitigate those biases and be able to communicate empathy effectively. And we can do it, when we're tired, and we can do it at the end of the day. We can continually improve on this, and there's very specific tools that we can use to do that, and there's very specific skills that we can learn that will help us along that road. And that's really what we spend the bulk then of the workshop talking about and practicing. We do a huge amount of practice for those of you who are familiar with the IHC's workshops, and the empathy effect is no exception. We use videos, we practice in pairs, we practice in threesomes, we have things like the popcorn quiz. We really practice the skills to be able to continually enhance communication for us. And with that, I'm going to end and turn it back over. I'm sorry. I wanted to share this one thing. Michelle and I get a real kick out of this, which is the IHC programs normally have an acronym to help remember the core skills, and the empathy effect is no exception. And in GEAR, that is the acronym. So there are skills associated with all of these letters. And the I is identifying internal and external cues that are clues that we might have a judgment or a bias. The N is, noticing the judgment, and then very specific research-based counter cues or cognitive correctives, some people might call them, to mitigate that. And then the empathy conveyance skills, goodwill greeting, empathic language, affirming strengths, and reflective listening. So these are really the skills that we start playing with and practicing in the workshop. And with that, I'll turn it back over to Kathleen.
Thank you, Elizabeth, and thanks for sharing, a lot of the examples with us to bring this alive and going over the quiz. Thank you to everyone for participating in that. So we'd like to open it up to any comments or questions that you have, and please take a few seconds to, use your chat button. Can you share the references? I see a number of questions.
Yeah. Yes, now I can see them.
We can share the references, and in fact, the last slide here is a link to the Institute for Healthcare Communications website, where they actually have a tab for all the bibliographies for all of the IHC's workshops, and the empathy effect bibliography is there. And we really encourage everyone to look at it. And also, if you have really interesting research references that you think should be included, it's sort of a living document, like all IHC bibliographies that we're really interested in always updating.
Absolutely. Thank you for that question. I see one about what is the typical schedule, and I'm not sure if what you're asking is the schedule for the workshop, how long it is. Elizabeth, do you want to speak to that?
Yeah, so there's two different answers to that question. The actual workshop is 4.5 hours long. Like all IHC workshops, there are continuing medical education available, like Kathleen mentioned at the beginning. There's the other answer to this question is that the IHC runs a train the trainer model, which we really encourage, because that means that at your organization, you have people who are certified to train the empathy effect. and that you're not having to call in outside trainers and, quite frankly, continually pay for outside trainers that maybe come once a year. You know, we really believe this is best taught by the people in organizations who are considered internal experts and influencers and already have a lot of natural skills in this direction. And so the Train the Trainer is a 3 3/4, so almost 4-day course where people from organizations, you know, you pick the people that you want at your organization to be trained, and they come and spend just a little over 3.5 days with us, the IHC faculty, and we train and then certify them to provide this to your organization.
Yeah. Great, thank you. I also see that someone asked, Tricia, thanks, if a learner has participated in IHC's other workshop called Treating Patients with Care, how would you describe to them the value of the EE workshop? So what I'm hearing is, what are the similarities and what are the differences? So Elizabeth, I know you've taught both, and so what's your response to that? What would you say?
Yeah, I think it's a great question for those of you familiar with the CARE workshop and even the IHC's motivational interviewing workshops, the clinician-patient communication and choices and changes. There's a lot of similarities, and the similarities are for sure the deep research base in all of these, the focus on evidence-based communication, and particularly a focus on conveying care and empathy. So I would say that that's very similar. One of the things that I think is different about the empathy effect is it is explicitly written for every level of health professional in any given organization. So many of you, it's appropriate for behavioral health organizations. And in fact, we piloted it with a behavioral health organization in San Luis Obispo, Transitions Mental Health Association. And it is appropriate for everyone from receptionists to physicians, to behavioral health providers, to medical assistants. And in addition to that, the empathy effect specifically speaks to empathic communication between coworkers. And that is new. That isn't explicitly in the other workshops of the IHC. So some of the videos are coworkers talking, and we're talking about how to respond to coworkers. So we've had people who were grant writers in this workshop. We've had people who were in billing in this workshop. We've had HR professionals in this workshop. So people who don't necessarily do direct client or patient care in this workshop, and we've got rave reviews from them. So I think that is one of the differences, that it's really the language, the videos, everything is really directed toward all levels of people and humans that we deal with in the course of work, whether that's coworkers or patients or clients, and that there's such that it can fit in any different type of healthcare organization.
Yeah. Thanks, Elizabeth. So there's also, there's two questions I'm seeing. One is there an online version of the workshop? If not now, in the future? At this point, there is not. And yet that does not mean that there won't be in the future. I can tell you that IHC has been working very closely with and partnering with another organization that happens to be in California, where we are doing some online module training in a number of topics, such as giving bad news, sharing serious news, and end of life and palliative care communication discussions. We're also in the process of working closely with a veterinary group in doing some online communication modules as well. So it doesn't say that maybe sometime in the future we may do that. At this point, we haven't. We love the power of working one-on-one in person, and yet we also understand not everyone can do that. So with your help, if anybody's interested in partnering with us on that and looking at that, we're always happy to talk about it. Let's see, how long does the training last? Are refreshers necessary? Now, I think, David, thank you for that question. I think the beauty of that question speaks to what Elizabeth just talked about, and that is the train the trainer portion. We find that if we come out and do a workshop, a half-day workshop, and that is the only thing that's done in that organization that speaks to communication training, there may have some very shortened effect, or it may actually have some impact for folks that are really motivated to improve themselves even more. If you bring trainers in from your own organization that do model the very skills that are being taught and actually have the capacity to teach it, they can actually work within that culture to use some other opportunities within that environment to keep this training sustained over time. And they can do this, and we know this in the 7 organizations that have participated in our first inaugural training for EE. Each of those organizations are evaluating the effectiveness of this training. So stay tuned for that. The other thing we know from other organizations is that there are some refreshers that people offer in their own environment. That's the wonderful thing about having in-house champions that can work with IHC to develop some sustaining ways of keeping that training going, whether it's refresher training, online, one-on-one coaching, getting together for some groups where maybe they read an article together and then they talk about that, how that impacts and keeps the momentum going for that particular training. I don't know if anybody else wants to add to that. Elizabeth, Catherine.
You know, I would just add one thing, which is one of the things that's built into the Empathy Effect workshop. The Empathy Effects Train the Trainer course is that we actually give the trainers that are being trained an agenda and support for a booster. So it can be an hour, it can be 2 hours. There's extra videos that are included in the materials that trainers receive. And so there's sort of a package that trainers get when they're certified that includes the ability to do booster courses. So as an organization, you don't have to decide to do the whole 4.5 hour training twice a year. You can decide that you want to do it with all new employees or all existing employees, and then every year a booster session or something like that, that you can figure out within your organization how you'd like that menu of possibilities to roll out.
Yeah, that's great. Thank you. And so I see some questions. I don't know if we're going to be able to get to everything, but there's a question about cost. And Barbara, perhaps you want to answer that, or Catherine? I'm seeing a message. What is the cost? Does the cost vary if you want to train multiple individuals?
I will quickly respond to that. Thank you, Doug, for that question. It depends. If it's a half-day workshop, as Kathleen and Elizabeth have said, we can send one of our senior trainers out to facilitate a half-day workshop, and that is a certain type of cost. But then a train-the-trainer cost, we usually estimate that on a per-person basis, the tuition, and that's an easy thing to get to you. So if you're specifically interested in that, there's a lot of notes and assumptions that go along with any budget. So it's probably a bit bigger a question than we have time for the answer, but I'd be happy to provide you with that information after the fact. So just send me an email and I will give you some more information on that, and anyone else who's interested.
Yeah, and Catherine, if I can just add one piece, and to Doug, one of the variants in the cost has to do with where the Train the Trainer program is held. So for instance, we are in the position to take these Train the Trainer programs on the road, if you will. So there are some organizations that perhaps want to train, more than 6 people at their site. And if they have the venue to provide that training, you are then considered a host. And if you do host the Train the Trainer course, there is a discounted tuition fee for that. So there are some, differential fees depending on if you host or if you're just sending one person to a host site, if that makes sense. And let's see, measuring impact. Another good question, David. And I know that our 7 organizations are using a number of different measurements to look at the impact of EE. And as I said, stay tuned for that. I don't have those. I know Barbara does. I'm not sure we have time, but certainly let's speak to that when we send out an FAQ document and maybe talk about some of the measures so we can address this question for David and anyone else. You know, I think that we've come to the time where we are going to have to end. I so appreciate everyone's interest, and you know, we will send out a document. This is recorded, and if there's any other information that you want, feel free to reach out to us. And Catherine, I don't know if we have a link for getting in touch with you, your email out there, but certainly there it is. There is the slide with info@healthcarecom.org. You can always visit our website and just pick up the phone and call us. We love that personal contact. So thank you so much.